Good afternoon, everyone. This is Valerie Cape at CMQCC. I'd like to welcome everyone who has joined us for our webinar this afternoon. To start, I would like to let you know that we have a couple upcoming webinars that I want to make sure you all know about. They are listed on the CMQCC website. We will be having one to introduce the maternal venous thromboembolism in pregnancy toolkit, presented by several of the task force members and doctors who worked on it. That will be April 12th from 12 to 1 p.m. Sorry for the error there on the slide. And then the other one that is coming up will be April 26th from 12 to 1 p.m. And it's on the induction of labor beyond the ARRIVE trial, the risks, benefits, and techniques for increasing success. And both of those webinars require registration, and you can register at the cmqcc.org website. I want to take a moment. I'm going to introduce our speaker today. I want to do a little bit of housekeeping. So Diana, you can go ahead and pull up your slides. We will be having everyone muted on the call, and we will take questions in the chat box. So please feel free to type them in the chat box, and we will address them at the end of the call. The last 15 minutes or so will be dedicated to questions. I want to introduce Diana. Diana Jolles began as a National Health Service Corporation scholar in the Rio Grande Valley of South Texas at Holy Family Services Birth Center. She was mentored there in public health, innovation, appropriate use, quality measurement, and implementation science. She is recognized as a national leader largely for her development of the Denver Health Medical Center inpatient midwifery service and her directorship of the Family Health and Birth Center in Washington, D.C. As faculty for Frontier Nursing University, Diane teaches innovation, quality improvement, and healthcare finance. As a scholar, her research includes evaluation of unwarranted variation in NQF-endorsed quality measures within populations of Medicaid beneficiaries. She works at El Rio Community Health Center in Tucson, Arizona, where she attends families at El Rio's Birth and Women's Health Center and Tucson Medical Center. So I also want to say that the slides from this recording from this presentation will be available on the CMQCC website, and the recording will be available on the CMQCC YouTube channel later this week. So with that introduction and housekeeping, Diana, I'll turn the time over to you. Thank you so much.
Thank you very much for the introduction. It's my great pleasure and honor to be here today to talk about prevention of change fatigue as we explore sustainability, spread, and scale. So these were the announced objectives, and I hope that you will find that we review these and are able to explore them, stimulate ideas, and generate discussion at the end. So I first speak today as a clinician. I've had the unique opportunity of working all across the United States. My partner is in federal service, so I move regularly. And this really did grow a passion for me related to unwarranted variations in practice, which you see, as any traveling nurses know on this webinar, you see unwarranted geographic variations quite often. And I bring that into the discussion. As a faculty member at Frontier Nursing University, we underwent a curriculum redesign in the end of 2015, where we now have integrated, through a partnership with the Institute for Healthcare Improvement Open School, rapid cycle improvement as part of our integrated curriculum within our Doctorate of Nursing practice. So since January of 2016, we've assisted students in over 239 rapid cycle improvement projects nationwide. So 51% of these are APRN and 49% nurse midwifery projects. The majority of them are outpatient. And the reason I'm telling you this is because you're going to see some of the lessons learned from these projects. All of our scholars have a 30-day planning period. A 3-month planning period, a 3-month implementation period, and a 3-month dissemination and evaluation period. There's a lot of benefit to rapid cycle improvement because you're able to have a start and end time to your projects. And that's one of the things that I think leads to The highest level of change fatigue is the fact that certain projects that need to end never do. And that will lead to great job dissatisfaction. So we are going to talk about these throughout the presentation and share some of the lessons. So to start off with, I want to share this is a very well used graphic out of the Institute for Healthcare Improvement, but it brings up the idea of spread and scale. And I really wanted to show this graphic to think about how are our changes sustained, spread, and taken to scale. This graphic says it perfectly because within 1 second you can see, gosh, it's all about social systems. We really are working on social change. And it's important to think about how our interventions are designed within our workload. What is the complexity level that is, are they simple enough to spread and let the social systems actually work on sustaining them without too much complexity? And how effective are our changes? If our changes are effective, the social system will take them and spread them without much effort. So end user participation is key. Alignment within the organization and within the national quality strategy is key, and we're going to talk a lot about that. Resource availability is another key piece to this. So do the people in your system that are responsible to spread changes, are they given resources to do this? So before we go forward, do me a favor and think about and jot down a project that you have that you're working on that's entering the sustaining phase. So that when we start talking about sustaining, you have a project in mind and you can try to think about how these principles relate to your project. Think of a project that you have that's in the spreading phase. And if you're involved in any projects to scale, which I would imagine the group at CMQCC could clearly link to a scale project, jot down that idea. What project do you think of about scale? So as you think of these three projects, whether it's a project in the sustaining phase, the spreading phase, or the scale phase, and you think about the challenges you're having, I want to think about some of the most widely scaled concepts that we have. Epidurals are to scale in our country. That is fair to say. And if you look back at the history of epidural anesthesia and how we led this to scale, it's consumer demand. This is a really important, the very first epidurals to United States, to our population, occurred because women flew to Europe to receive epidurals. So this is one example of an innovation that moved to scale that started with consumer demand. So that's a positive deviance example of innovations moving to scale. Electronic fetal monitoring has moved to scale in the absence of scientific research to support its routine application among normal, healthy, low-risk women. Yet it has moved to scale like wildfire. So think about, what was it that led electronic fetal monitoring to move to scale? And when we're starting to look at how we're going to scale innovations, what can we take from this lesson in a positive way and apply it to our scale? Here's another example, the routine use of radiant warmers for healthy newborns. And I don't know about what's happening in California right now, but I can tell you from my personal practice and in recent years, the overuse of radiant warmers is still prevalent. And in many systems, we're giving ourselves credit for the golden hour, which is sort of something that never should have been taken to start with. And the limitation to a 60-minute time period is artificial. So this is an example of something that's gone to scale that's been misused or overused. But what were the factors that led something like this to move to scale so quickly? So this is sort of a look at where are we at in the United States with regard to our healthcare redesign and innovation. So these were the IOM rules for healthcare redesign. And what you're looking at is a sample of 134 advanced practice nurses who are in practice nationwide. The sample is 29% rural, 30% suburban, and 40% urban. 73% are in practice in outpatient settings, and they are in their final term of a doctorate of nursing practice. So they are educated in the concepts of healthcare redesign and innovation and quality improvement. This is not research, it's simply a survey that's looking at what is their impression and opinion about healthcare and the system where they're in. And it's concerning. And I don't think it will surprise anyone who's practicing right now, but we scored an E on continuous healing relationships, in that we aren't hardwiring these into the system that we're practicing in. A D with regard to customizing our care to meet the needs and preferences and values of our patients. And an E with regard to patients as the source of control. So this is just a reminder of where we're headed as we're thinking about scale. How are we going to redesign our healthcare system and turn it upside down? So this is more from that same survey. Again, an E with knowledge sharing, an E with evidence-based decision making, and this includes etiological variations from clinician to clinician, an E with regard to health transparency, and an E with regard to the system's needs, anticipating what the patient's needs are, which is something you can do ahead of time. So I wanted to start with some cross-cutting ideas that go from implementation, from planning implementation through implementation itself and evaluation, through all the different stages, whether it's in sustaining your gains or in the spread periods or taking it to scale. These ideas wind up being cross-cutting across all of those. So things that cause fatigue in your team, not aligning with a larger movement. So there's always going to be change ideas, but when you're planning, implementing, and evaluating, when you're sustaining, spreading, and scaling, it's important that you ask yourself, this particular initiative, which Institute of Health of Medicine quality aim are we working on? Being very specific, having time-limited projects that are specifically aligned with the National Quality Strategy, the IOM redesign principles. I think everyone's understanding of how important the National Quality Forum endorsed measures are in respecting the fact that there's been a multi-stakeholder endorsement process, and in buying into the process that fewer measures is better. And if we focus, we will do a better job at aligning all of our work towards the ultimate aim of a redesigned healthcare system that's sustainable. So we'll talk about the Pareto principle, but that's the idea that 80% of our effect is coming from 20% of the causes. And it's really important that as we select our improvement initiatives, we're being careful to really go for low-lying fruit and the biggest bang for our buck, or else we will drain our teams across the entire process of quality improvement. So learning to separate the vital few from the trivial many and having a very clear aim that is aligned with the National Quality Strategy will help to prevent change fatigue. And continuing to remind people along the way is an important strategy. So I wanted to share these two important things that really changed my experience as a quality improvement leader. I was at an ACNM conference some years back when Jolles presented this. She was lecturing on quality, and she talked about the Aesop's fable of the three blind men and the elephant. And I hadn't thought about it in a while, and ever since then, it's affected everything I've done and every project I've done. And if just to remind you, it's a story of the three blind men who come upon an elephant, and each one is coming from a different standpoint. And so the one on the top, of course, says, this is a fan. And the one at the bottom will say it's a snake or a tree or a wall or a rope. And the key and the art in building teams and in affecting change, whether it's in the sustaining phase or the spreading phase, is to take the multi-stakeholder variations and embrace them, maintain them. Don't try to assimilate and change people. Rather, take their diversity and bring it together at the common point where you can. And that is the place where you will affect the most change. Another thing that happened to me related to elephants that was very formative was during a management retreat that we had at Denver Health Medical Center, where one of the leaders gave us a book called Don't Think of Elephants. And the entire point of the book was, of course, anytime you tell someone don't think of elephants, what do they think of? Elephants. So you never want to lead quality improvement by focusing on the negative. You want to focus on the goal and where you're headed, not where you don't want to be. So I think the best example of this is your normal newborn complications metric. That's an example of using appreciative inquiry. But I can give you examples of quality improvement projects, for example, with the Joint Commission measure on exclusive breastfeeding. I worked in an institution many years back where 0% of the newborns among the population, 80% of the women intended to breastfeed. 0% of those newborns left the facility exclusively breastfeeding. So the way we changed that was never focusing on the formula that's being given out, but instead focusing on the one case where we could get one element to work, for example, skin to skin in the birth room, or the transition period. And by continuing to focus on one issue that worked, the one issue became 2, the 2 became 4, 4 became 8, and that's how we grew it, all through the use of appreciative inquiry and trying to stay positive. So a couple other cross-cutting lessons that I've learned, and especially in watching our adult learners who are implementing nationwide. Excellence is the enemy of good, that good saying. It's hard for adult learners to fail. And if you're not embracing failure, you're not on the edge of quality. So learning to fail and learning what things don't work is just as important as embracing your successes. You're way better off to pilot something that flops and not waste your time spreading it, and really embracing that failure in some way. And that's an important thing. Staying on the edge of learning and respecting the need to pilot test your hunches and ideas. Listening to what data comes back to you is important, and being willing to let go. I think that it is never the right time to do quality improvement, and I've definitely noticed that in the last 120 implementation projects that I've been a part of. If you just think back to what has happened in our country from 2016 to now, the Houston floods, the various hurricanes, we had students in those areas and leaders who were implementing changes. We had 2 Joint Commission spot check visits during our implementation. Right when you go to do a site visit is exactly the day that the patient will come in saying, oh, the cordy thingies hang out at my knee, right? It's just never the right time. It's almost a joke. But learning to continue onward with the appropriate level of pilot testing before you scale up will help you continue to move through the projects in a way that's satisfying for people. But if you continue to wait for the right time, which will never happen, you'll really prevent the perseverance and the grit that is part of preventing change fatigue. You have to allow those things to continue on. The top, I mentioned what I consider to be the joy breakers. Everyone here who's involved in quality improvement is likely doing this as a volunteer opportunity. There's so much quality improvement going on right now that's not part of people's daily job descriptions, and it's not carved in workload. So things that really make this experience not fun are when people have to constantly find themselves apologizing for being late or apologizing for something not happening. So when you're volunteering and when you're leading teams of people who are volunteering, it's really important to appropriately size and scale the projects so that people are set up for successes. Otherwise, you will cause extreme fatigue. So One of the most important things to preventing change fatigue is really appreciating the phases of quality improvement: testing, implementing, and spreading. So when you talk about sustaining change and spreading, you actually do, in between those two processes, have to retest. So if I got something to work at my clinical site, but I'm going to spread it across to another federally qualified health center site across town, I still have to go through a pilot testing phase and engage all of the stakeholders at the site in order to adapt the implementation intervention, and also as an important process of gaining buy-in. It's the continual spread of buy-in that becomes as important to these projects. So this is a review, you probably will recognize this, Everett Rogers Diffusion of Innovations. This is quite old, but it rings so true to everyone who's working in quality. You have your innovators, your early adopters, your early majority, your late majority, and your laggards. And every single personality type here, and you get many blended types, every single person has an important role in the various stages of pilot testing, implementation, sustainability, and spread. And one of the most important pieces is not getting yourself so siloed that you only have a couple QI people. You have your QI department. You have your few QI clinician leaders. You want to spread it as much as possible. And some of your laggards can be the most important people when it comes to sustainability or spread. So this is the hardest topic we see our collective academic community struggling with. We're so trained in science to come in with a plan, implement your plan, and study that it works. And that is so the opposite of what we all know works in quality improvement. First of all, your plan has to be well selected. Don't just go after the first project idea you have. Make sure it's meeting the Pareto principle and that you really have consumer demand and it's aligned with the national quality strategy and the things you're already doing as an organization. When you go to create the plan, make sure you're involving everyone who's involved, especially any person who it affects their workload. And then you have to be open to constantly changing your plan. So one of the lovely things about rapid cycle improvement is the idea that you're there to embrace its mess and its chaos. And your goal is to have interventions reliably work within every chaotic situation. So if it's not working during the hurricane and it's not working during everyone's vacation and during the big mega blizzard, it doesn't work. So you have to find ways to make it work throughout all of those chaotic situations. So in the literature, you will consistently see one of the most important things to prevention of change fatigue is hardwiring the communication. So building strategies that foster and support spread, relating to how you're communicating, when you're communicating, how often you're communicating. And all of those things should change depending on what's happening with the project. So I'm just joining a project right now. 2 weeks ago was our first kickoff meeting, which was set when 50% of the people couldn't be there. That's an issue. I got 5 emails in 2 days to 2 different email addresses about the project, which is the first way to get me to tune it out, because if it's not streamlined communication that's efficient, I won't be able to keep tuning in. So these are just examples of what we do. We don't mean to do it, but it happens. So you can really get into fatigue based on how we're communicating, how often we're communicating. So the communication also, we have a parallel system. So I can log into the QI system to monitor and track QI projects, but it doesn't flow into my workflow ever. So I have to remember to log in, and that's a problem. So you have to have integrated systems where communication flows naturally and it's effective, but not over the top. My favorite thing to drive me crazy are group texts. Like, I can't have 50 texts going on about this project or about a clinical situation or whatever. And I think everyone can relate. So what you have to do as a team is develop strategies. And I'm going to go through some of those. I share this picture with you because it's a fun story of Megan Lewis, who's a family nurse practitioner at a rural clinic in Hawaii. And she was working on integrating oral health screening and fluoride varnish during primary care. So all of our students are required to work on interventions that address team building and team buy-in, and also patient engagement, along with 2 other core process changes. So Megan's plan when she started was to have weekly team meetings and during these team meetings, they were going to go through training to formally help them be certified as providers to provide integrated oral health care, which was great. I can remember talking with her, are you sure your team is going to be excited about getting together in the same room once a week and going through these modules? Oh, yeah. So, of course, we're always a little overly optimistic about how feasible these kinds of things are. But the thing I really liked about watching Megan work through her project is by the 4th PDSA cycle, not only were they not working through the modules, they were actually hiking. So she would take her team on a 1-hour hike, and they would be dealing with the project and talking about the project and building the social network. But that's what wound up working with the team. And that's what it's all about. So not sticking only to what you think might work or what you're going to force to work that won't work, but actually making it happen. So she was able to build a strong community there, and the project itself was very successful. This was another kind of aha moment I had. It wasn't a clinical QI project, but it was a professional project where a group of, this is a long-standing tradition called The Gathering, where a group of nurse midwives and licensed midwives from Texas get together for a weekend, and they have this vision of interdisciplinary collaboration, interdisciplinary education, and all the while it's in an aesthetically pleasing setting, usually on a ranch somewhere. It has to involve receiving 14 CEUs and can only cost $60. So imagine this, like setting up the impossible. Well, one year I agreed to lead it. The only reason I agreed to lead it was because I had sent out a survey monkey to the entire group and solicited volunteers who filled out this survey monkey, because one of the questions on the survey monkey was, are you willing to donate 8 hours of volunteer time to help organize this for the next 6 months? So I had 17 people who had agreed. And that is what helped me to decide, okay, I will lead this because I have the buy-in and support. Well, this is where you can imagine the story falls apart, because you've probably done this before. You have your engaged group, everyone's excited. I held my first meeting, maybe there were 3 people there. I held the next meeting, 5 people. You know, I was so far from my 17-person engagement. Anyone in their right mind would have probably had a little bit of an attitude about this and just moved on, and probably cut off those people who said they would do something who didn't. But I just kind of played around to see, well, what will happen? These 17 people said they'd help. And I'm going to continue to believe that they mean this. And I'm going to keep best intentions in mind, and we're going to keep going. So every meeting I had, I distributed minutes to everybody, not just to the people who came. And I held those 17 people on this list and continued to communicate, not with too much frequency, but what felt appropriate. And would you know, by the end of the event, all 17 people were engaged, and all 17 people volunteered at that amount of time. Now, some people, it was only at the event itself, but it didn't matter. So it was the point of getting a group and then just agreeing to standards of communication and continuing to engage people even who can't attend, because many people will pull through. And even though they might not be actively engaged with certain things, give them the chance, give them the benefit of the doubt, and I hope that you too will be pleasantly surprised. So after this, it's become the way that I've managed several QI projects and continue to do so. One of the nice things about using an application like SurveyMonkey to organize your project is I'm able to say and look ahead and say, okay, these are the 5 elements I'm anticipating or the different phases or interventions or things I'm going to need help with. And you pretty clearly, if you have 17 people responding, only 3 will be interested in analyzing the benchmarking data or in producing one-page policy briefs on the implementation findings. So you can actually target messages and project management through just use of this one survey if you maintain it. You can figure out who has big vacation plans and during which month, so that then you're not bothering them during those months. But there are great ways to really organize your communication and make sure that you're keeping the team together without overburdening them. So I wanted to talk a little bit about prevention of change fatigue and hardwiring communication in large teaching hospitals and urban settings. This is part of that piece of really anticipating the needs of the organization. When you're in the piloting phase and you're part of the implementation, and then you're going to the sustaining phase, it can be really frustrating saying the same thing over and over and over again. So it's easy to realize that we're going to have turnover. You've got your medical students coming in, you've got your residents, you've got new nurses, you have different attendings. And so really finding ways to structure your orientations is important. Looking at how you're messaging and training and making sure that it's not the same people every time saying the same thing over and over will help you prevent the change fatigue. So if you think about your board report and how your whiteboard is organized, and let's say we're going to talk about quality improvement that's based on preference-sensitive care and the patient being the driver of change, I would ask yourself, on your whiteboard, do you have a column there that states what the patient's preferences are? That helps your team plan care around the patient's preferences. So you have to hardwire the patient onto your board report if that's where you're doing your care planning and your communication. So think about how that's being done in your setting. As far as competency days, there are a lot of things that we're doing with quality improvement related to birth and related to normal birth that need to be integrated into your competency days. So if you have a skills day, are you doing interprofessional drills and communication simulations? What type of intermittent auscultation competencies are you running on your competency days? Are your quality metrics that are most important to you embedded into your performance evaluation for your nurses, for your providers? And how is the patient satisfaction being communicated at the provider level, at the unit level, and is it integrated into the performance evaluation? So these are all ways to hardwire communication and prevent the change fatigue, so you can select and be very discriminating which quality metrics you're selecting. Do they meet the qualifications of being aligned with the National Quality Strategy and the NQF endorsed measures? But once you've got that, is it being given back down to the individual level for people? So just a look, this is just another random survey. So this is 316 advanced practice nurses. 29% are in rural areas, 30% practicing in suburban, and 73% are practicing in outpatient settings. So only 42% can say that there is a robust follow-up on quality indicators within their clinical setting. With regard to continuous performance evaluation, 25% saying that there are actually ongoing continuous performance evaluation occurring related to quality metrics across these settings. And remember, 40% of these were urban. So we have a long way to go. When you look at the different phases of sustaining your project, spreading, and taking to scale, what types of things are you doing to prepare yourself? You think about sustainability, it's all about holding those gains. So it's quality assurance and performance metrics and making sure that you're keeping an eye to make sure you're not falling back on those gains. If you look at spreading, you're actively disseminating best practice and changing it and moving it across sites, at which point you have to repilot and move forward from there. So that's the piece of spread across practices, spread across sites, spread across the state, and that you're familiar with at CMQCC. And scale, that's more of a policy issue. So once you're getting into scale, you're looking at the infrastructure and what's keeping and what is going to support innovation and drive innovation. So scale is typically at the public policy level, and it's looking at reimbursement, it's looking at payment and sustaining innovation on a large scale. And we're going to talk about the differences among these. So in order to sustain the gains, there are some key pieces here that came out of the Institute for Healthcare Improvement in 2006 in their framework for spread, which is listed at the end. Supportive management is important. Can't say enough about leadership. I will say this, of all of the implementation projects we've had an impressive amount of change and significant improvement on nationally endorsed quality metrics in a short period of time in projects that are not being led by the management. So yes, of course they have support because they're aligned, but clinicians can make a big difference. And so even in environments where there is limited management support, we have seen great success. So I don't want to discourage anyone because I know that that's something that's outside of your control. Structures to foolproof change, we're going to focus on that, and robust and transparent feedback mechanisms. I want to start, when I look at structures to foolproof change, talk about how are you hardwiring your patient's preferences. So decision aids, are you formally capturing patients' preferences and values? And which metrics are you reporting back to your providers, to your team? This is the way to drive patient experiences of care within your system, and they have to be hardwired. You can do patient tracer pathways. Is the system as a design, the point of systems design, getting the right patient to the right provider at the right time? Foolproofing change has a lot to do with backwards design. So once you've identified the idealized design, it's about making sure that this is what happens all the time. It's a systems property. You would have to opt out and do workarounds to not do it right. You shouldn't have to do your workarounds to make it work right. You shouldn't need 20,000 clicks in the electronic health record to do the right thing. It should be reversed. So this is only possible through interdisciplinary, cross-departmental hardwiring of right care within your system. So there are some examples of this in how your system is is matching the patient's needs, their level of care need, with the right team at the right time. So measurement and audit is a really important part of this, and being transparent with your measurement and your data. So making sure that you're not just measuring it. It's like now in our healthcare systems, we have so much data. It's all over the place, but we fail to analyze it, and we fail to get it out to the people who are your core stakeholders and who can make changes. When you're looking at standardizing your processes, there's a good joke about the best way to get a message out is have a very small and exclusive meeting with a few people and tell them about a confidential issue. That will spread like wildfire. The worst way is to release a policy or a guideline. It would never get done. Sits on a shelf, sits in your email, it's not part of the workflow. So you really have to get your policies and guidelines integrated into your electronic health record and your workflows, which takes an interdisciplinary team to make sure that's happening. So sustaining the gains and spread. So these are more ideas. This also coming from the IHI 2006 framework for spread. It's the infectious excitement that happens when you do the right thing for the patients and when you're able to realize the quality improvement. So you have to honor the cycles of quality improvement, which includes planning, implementing, and sustaining, but acknowledging that it's stopping. So you have your rapid piece of change, and now you've entered into a new phase. So that's where you need to harness the energy that came from that success and let it build, and then get your next layer of leaders. So you're growing new improvement leaders when you do that. So you really, really, really have to build that sense of deeply engaged staff who aren't being overburdened or burnt out or set up for failure. And that involves formal capacity building programs. So it's not enough to have one day in service to say, hey, this is our new thing, our new initiative, click here, click there, and then throw them out into the workflow where none of that is integrated, they didn't get to practice it, and they don't have an IT specialist with them to help them build it into the workflow. So adult learning takes a lot more than that. So I want to review the 7 spreadly sins. This comes out of the IHI, and I think it rings true to everyone who's doing quality improvement as you've experienced these things. With regard to spreading successful improvements, these are the 7 spreadly sins. So giving one person the responsibility to do it all. You know that, you've lived it, you've tasted it, it does not work. So this is something we have to avoid. Relying solely on vigilance and hard work. Again, back to the volunteerism. We have to find ways to build workload into a multidisciplinary team of QI people so that it's not siloed into a department, but actually spread. And that way you're increasing more buy-in, you're increasing a way to spread the workflow. Spreading success on change. So again, once you have success on a unit, just saying we're going to take it to the next unit without running a small pilot with rapid cycle improvement methods is a mistake. Requiring the person and the team who drove the initial improvements to be responsible for spread. And I can speak personally to this, having moved several times. I have unnaturally been taken from my QI projects, and I've learned that there's a great blessing to that. So I've been able to innovate, and I've been able to be the person who can lead to rapid change. But what it takes to sustain change is significantly different, and the personality types it takes are significantly different. Back to that Rogers spread of innovation. Think about that and think about how it applies to your system. Expecting huge improvements and spread right away. So you see this all the time. Institutions implementing something not on one unit or with one small group of providers, but just saying, we're going to implement this across all our units right now or across 4 hospitals. So you really do have to honor the stages and run those small tests of change and pilots prior to expecting huge improvements right away. Again, you have to pilot test. And then this is a classic issue, which is checking huge mountains of data just once every quarter. So that's not a good way to do anything. It will lead you to great burnout. And it will also lead you to not be responsive, to not be in touch with your data. And it's not a good thing as far as your ability to continue to increase buy-in. So scale, I'm going to talk just a little bit about scale. I think that when you look at scale, this is now taking it to a national level, and CMQCC is our best example of scale when you look at quality improvement collaboratives and all of the work you've done that's now gotten to the national level and has really spread and is continuing to do so. But this is all about really stopping the infrastructure barriers. So you can't do this if the payment won't support it. Centering health works, but if we can't get reimbursed for it, it doesn't, it's an idea, right? There are many examples of that in our work. So these are the 9 levers of the National Quality Strategy, and they're very similar to the things we've already spoken about with regard to alignment with public reporting and quality metrics, making sure that your workforce has learning and technical assistance, integration into your electronic health record. But think about, I want to put a plug in here for certification, accreditation, and regulation. When you think of things like the Joint Commission Perinatal Certification, the levels of care movement and regulations, Centering Health Certification, CABC accreditation, these are really the backbone and art to scale, because these are what keep you from morphing every time you spread to a different site, morphing so far away from what the essential elements of the intervention are. You have to modify to make it work in the real life situation, but you can't modify too far. And so it's through certification, accreditation, and regulation that you can really make sure that your scale is going to be effective. So if value and these issues are important, then we realize that we should be getting feedback. And this is just another survey of 315 advanced practice nurses, asking them, well, are you getting any feedback? This is not even on your value metrics, but on your billing itself. And you can see that only 40% report that they have robust billing audits. So we really need to be closing our feedback loop on our billing and our coding and our collections. Now this is moving up to the next level. This is a sample of 134 doctoral students in their final term. And this is looking at whether their organization is participating in high-level population health performance metrics, including value and cost. And you can see only 26.5% are reporting that. So we still have a ways to go. So I wanted to run through a positive case study that will help you see some ideas of a real-life project that has sustained itself, started as a pilot. So I had the privilege of joining Denver Health Medical Center in 2005. Denver Health's motto is level 1 care for all. And what they realized is that they had 80% of their clients coming in labor saying they did not want an epidural, and 80% of their clients received an epidural. So it was a patient preference issue that wasn't, they weren't meeting their patients' preferences. And the same was true for their breastfeeding intentions. So in 2005, we piloted, and I just want to explain this pilot. This is quality improvement data, so I'm not presenting this as research. Your national rates are coming from the Listening to Mothers survey, which is the only nationally reported information we have on these types of measures. The 2005 sample is a sample that looked over 269 admissions. It includes only women who qualified for entry to a CABC accredited birth center. So we were really looking for the low risk women. We wanted to see, it was everyone in spontaneous labor, Vertex, Singleton, normotensive, no meconium, reassuring fetal surveillance on admission, who preferred no epidural. And so you can see that among that population, they weren't getting physiologic labor support. We implemented a pilot over a 6-month time period to significantly change the way people were being cared for by adding midwives to the intrapartum unit. It started as a nighttime pilot and then spread. And you can see the results. Now, the 2010 and 2015 results are looking at all women. So it's not selected for only women who didn't want an epidural. It's actually, this is data coming from their ongoing tracking system. So their transparency, performance evaluation metrics. So these are more examples of things that we put in place to measure and try to track over time to make sure that we're sustaining the gains. As you know, it's hard to do in a large urban teaching hospital. We have a lot of turnover, and I just want to demonstrate some of the ways that we did it. Like every other project I've been part of, it's all about the team. So it was really important for us, the physician support that we had from the start of the project and continue to have today are crucial. So it's truly an interprofessional team, but where the midwives that were added are valued as specialists and as team members. So there is a lot to how the team was built from the beginning and how the team is sustained throughout. It's constant work, and it has taken several different people with several different characteristics and personality types to make it happen. But development of leaders, both formal and informal, has been a crucial piece of this project. I think that it's a mistake. You don't actually ever arrive. So we got the project up and running, then it grew, then we were 24/7, but you're constantly dealing with the issue of maintaining trust and navigating personalities and team building, and that can be fatiguing. I know that in this case, I can say that turnover on the team was a healthy thing. It wasn't intentional, but it was something that probably was a good thing. Having all the players at the table is important, and then also this service has helped to spread to other hospital groups. So what we were able to do as an interprofessional team has spread across the organization into outpatient sites and other reviews. Things we did to hardwire communication are the QI peer reviews. We actually have interdisciplinary peer reviews. The midwives also have distinct peer reviews related to the hallmarks of midwifery. Formal feedback is given on IPE. We keep metrics on what people's percentages of intermittent auscultation are, and you can start to see outliers or people who are struggling with physiologic birth or need support. Another example of scale, and I already mentioned this, was the transformation that's happened on the national level. So Denver Health is an example of a system that was able to pilot a project, grow it, sustain it, and we haven't quite moved the model to scale. I don't know that we will. I hope we will. But I can say that CMQCC is well on its way to moving your model to scale, and I look forward to the day when it is at scale, and I want to compliment you for that. So if we go back to that original slide about interventions that have gone wild and spread and scale that's happened sometimes in the absence of data, and what makes those technologies or interventions effective. Consumer demand is a really important piece of this, and we always want to keep it a piece of it. But consumer demand doesn't always look like we think it does. The consumer shouldn't have to say in medical terms what they want. They should be able to express their preferences and values using standardized tools. And we as a system should be designed to provide the right level of care without the person needing to be able to state that, as we're the experts and we're the systems designers. One thing that is true as far as spread and sustainability with social change is that it has to be integrated into the workflow. Nothing is more important than your interventions being seen as effective workflow interventions that make your team's job easier. So for the last, I actually spoke longer than I intended to, so I apologize about that. But for the last pieces, I'm curious to take questions and to hear more about what you're doing to make sure that clients are driving your changes, how your team is sustaining the change, and what types of processes you have hardwired into your system to support sustaining and taking projects to spread or scale. And I did want to give a shout out to Dr. Buzz Brown, who is facing retirement, and he was our physician champion at Denver Health. So there are references on the slide deck of some key IHI resources, and And at this point, I would entertain questions.
Oh, Diana, thank you so much for that wonderful presentation. I think there was so much information there. I think we're going to have to listen and watch again a couple times to digest it all and see how we can apply it in our settings. I want to encourage everyone, if you have a question, that you can type it into the chat box now. We'll wait for a few minutes if there's any questions that come up on the chat box. And the slides will be available. We will have them on the CMQCC website by the end of the week, and the recording will be on the CMQCC YouTube channel. At this time, Diana, I'm not seeing any questions. Just a lot of thank yous and thanks for the great job and thanks for the great information.
My pleasure. Thank you guys. And
I want to thank you for all the complimentary things you've said about CMQCC. I will pass that information onto the team and onto Elliot Mann, our medical director, who has worked really diligently to try to do alignment in the United States. So there is one question that's come in. How do you get folks to want to be on the team?
So I think, gosh, there's, it's a great question. We have all kinds of resistance in all kinds of different settings. So we're working with everything from a private practice with one provider and maybe 2 other team members to, of course, huge projects where you've got 70 staff members. And I think that the most important piece to getting people to want to be on the team is first creating a sense of urgency about there being a significant gap that's harming the clients, because that drives people. No matter all the different funny personalities we have all over the place, everyone that I've met cares about the patients. And so keeping focused on the patient and the voice of the patient is the most important thing. What we did at Denver Health was only possible because of that, because everywhere along the way there was a stumbling block or an issue. And we always went back to, but what did the patient say they wanted? What did the patient need? And so I think building momentum around really looking at your patient experience of care, capturing that data and sharing it, and then embracing all of the ideas. It's always true with every implementation term we have at Frontier that every student will tell you a success story from someone on the team who drug their feet, who finally came up with an idea after they decided to play along, or even while they weren't playing along, while they were telling you the 100 reasons they weren't going to do what you wanted them to do, they came up with the brilliant idea and the brilliant pearl of it won't work because of this. And then you say, oh, you're right. You're right. Thank you. It won't work because of that. And now we're going to incorporate your idea into this project. And once they start seeing that flow and seeing the success, and once you're sharing the successes and acknowledging who deserves the credit, the frontline people who are sitting greeting the patients at the medical reception desk, or who your MA who's onboarding the patient, as long as you're continually sharing those successes, it does spread and the enthusiasm does build.
So there was another comment about what to do when no one is aboard for a QI project, like a unit full of slow adopters, and then in addition, how suggestions on fostering management support for change projects. And then we'll probably have to end at that time because we're almost at time.
Okay, I think those are great questions. Again, with the Denver Health Project, we were very fortunate to have an extreme physician champion, and we would never have achieved the success we did. We had a team of 11 supportive attending. And when I say that, not everybody bought in completely to the vision, but no one was against the idea, right? So when you have a whole group of people who are negative, if you can't bring them on board based on the voice of the patient, I hate to say this, but I'll say it. There are times when natural turnover is a healthy thing for an organization. If people don't care what the experience of the patient is and about improving care for the patient, and they're not aligned with your organization mission, there are other really amazing candidates for their job. I think I'll end on that note.
Okay, well, and I would just want to again say thank you to Diana for this great presentation, and thank you to everyone who has joined us. We will look and see if there's any more questions, and we'll get back to those people who have asked questions that we don't have time to answer. So thank you so much, and we'll sign off at this time. Bye-bye.
All right, thank you.